Hello, welcome to Pediatric Pulse. Today we are learning the ABCD approach of the critically ill child. Here are the specific assessment and actions in ABCD. On approaching the child, note the general appearance of the child. When assessing for the general appearance of the child, you can assess using the pediatric triangle. It has the following components: appearance, work of breathing, and the skin color. For appearance, you assess for muscle tone, interactiveness, consolability, look and gaze, and the speech and the cry of the child. For work of breathing, the signs to look for are abnormal breath sounds, abnormal positioning, retractions, that is chest retractions, and also for nasal flaring. For skin color, you assess the color and the perfusion. The indicators include the pallor, mottling, and even cyanosis. Also note the child's interaction with the caregiver or the parent or even the environment. This will enable you to know if the child is unconscious, conscious, or even obtuned, and this will guide you in your management. So we are starting with the airway. On the airway, we start by assessing the airway patency. So for patency, if your airway is patent, ask yourself, is the child conscious and is the child vocalizing? Is the child's airway at risk? An airway is considered at risk when there is a potential for obstruction, but it is not currently obstructed. Maybe due to swelling from an allergic reaction or infection, trauma on the face or on the neck, neurological conditions like Guillain-Barré syndrome, or even a foreign body that could potentially move and block the airway. Is the child's airway obstructed? An obstructed airway occurs when there is blockage that prevents the air from passing through the airways. It can be partial or even complete. For partial obstruction, some air can still pass through, but it is difficult to breathe. The child will present with symptoms like wheezing, stridor, or even labored breathing. For complete obstruction, no air can pass through, leading to an inability to breathe. This is a medical emergency that requires immediate medical intervention. Common causes of airway obstruction are foreign objects like food, toys, or even coins. Swelling from the neck due to severe allergic reaction, that is anaphylaxis, infections like croup, or even epiglottitis. Also trauma to the airway. Here are some actions to take on the airway. The first one is head positioning. Ensure you use jaw thrust maneuver or even head tilt chin lift maneuver to position the head and to ensure that the airway is patent. If it's a neonate or an infant, ensure the head is in neutral position, and if it's a bigger child, ensure the head is in sniffing position. Another action is suctioning. Suctioning will enable you to remove secretions in the airway and to prevent obstruction. You can use oropharyngeal airway, which are airway adjuncts, for easier suctioning and maybe later for easier ventilation. Kindly appreciate different sizes of oropharyngeal airways here. You can also consider the use of advanced airways, for example, endotracheal tubes, laryngeal mask airway, and I-gel. B is for breathing. At B again, we assess the conscious level by the use of the AVPU scale. We assess for air movement through look, listen, and feel. Assess for respiratory rate according to the age of the child. Assess for chest expansion, use of accessory muscles. Assess for chest recessions. For example, sternal recessions, intercostal recessions, and subcostal recessions, and sometimes the child might present with tracheal tugging. Use techniques such as palpation, percussion, and auscultation to assess the chest. Ensure that you have attached the child to an SpO2 sensor to assess your SpO2 and also your FiO2. Also, recognize the signs of respiratory distress, for example, increased work of breathing, nasal flaring, use of accessory muscles, and respiratory failure or signs of impending respiratory failure. Here are some actions to take on breathing. The first action is to provide supplemental oxygen through various delivery methods. One can be use of non-rebreather mask, oxygen mask, nasal prongs, or even the bag valve mask. Another action to take is to initiate assisted ventilation by the use of the BVM, which is the bag valve mask ventilation, or even mechanical ventilation if needed. At this point, we also monitor the end tidal carbon dioxide by the use of capnography to assess the ventilation adequacy. At C, we have circulation. For circulation, we assess for heart rate, blood pressure, and peripheral perfusion. So the first thing you note or observe is the evidence of hemorrhage and fluid loss. We also assess for level of consciousness by the use of the AVPU scale or the GCS score for pediatrics. We assess the heart rate as per the age of the child, the capillary refill time, which should be less than 2 seconds. You can assess for capillary refill time at the nail bed or even at the sternum. Assess for presence of distal and central pulses. For the pulses, we assess for their presence, regularity, and the volume of those pulses. Assess for skin temperature and the color of the skin. Assess for your blood pressure according to the age of the child. Another thing you assess for is the urine output. For the urine output in pediatrics, the normal should be 0.5 to 2 ml per kg per hour. On circulation, the first thing you do is to initiate CPR for cardiac arrest. That is, use of chest compressions, defibrillation, or even medication administration. The second one is to control any visible external bleeding, either by use of tourniquet or even applying pressure on the bleeding sites. Attach the child on the monitor by use of 5-lead or even a 3-lead ECG. Obtain an IV or even an IO access for drug administration and obtaining of blood samples. Estimate the weight of the child. If you have not reviewed our video in this channel that is showing how to estimate weight in pediatrics, please go and review. Another action that you take is taking the blood sample for simple lab tests or routine lab tests. Another one is the bedside glucose estimation. If the glucose is low, ensure that you correct at this point. We use 2 to 2.5 ml per kg of 10% dextrose. Another thing is fluid bolus. Fluid bolus, we use 10 ml per kg. Reassess and intervene when necessary, and also seek expert help. In this slide, appreciate the IO access and the sites. At D, we have disability. Here we assess the level of consciousness, pupillary response, and motor functions. Here we also identify the causes of reduced level of consciousness. Is it neurological, metabolic, or even toxicological? We also assess for the AVPU score of the child, or even use of the GCS score for pediatrics. Interaction with the parent or the caregiver and even the environment, posture and muscle tone, pupil size and reactivity. I hope you can appreciate the different sizes of pupils on the side of the slide. The normal pupil should range between 2 to 4 millimeters. The size of the pupil is affected by different factors. It might be age, it might be medications, it might be neurological conditions, and others. Actions to take at D. Reconsider ABC management as conscious level dictates Establish bedside glucose estimation. If low, give 2 to 2.5 ml per kg of dextrose 10%. Establish any medications have been given or possibly ingested like in organophosphate poisoning. Reassess and intervene when necessary, and always summon for expert help. At D again, we manage the underlying causes like administering anti-epileptic medication or treating the metabolic abnormalities. At E, that is exposure, we perform a comprehensive physical examination. We look for specific signs of an exposure like bruising, abdominal distension, cyanosis, and consider their implications. Also note the evidence of any blood loss on the skin, lesions, wounds, drains, or even rashes. Hope you can appreciate at the corner of the slide a meningitic rash. Also assess for your core temperature. Actions to take on exposure. Address identified findings, for example, hemostatic measures, surgical consultation, or even fluid resuscitation. Also, you can consider starting your antibiotics early for sepsis. For example, if you have seen a septic rash. In this slide, we also consider temperature control, either warming or cooling as needed. In this slide again, kindly appreciate the different thermometers we use on children. Here are some points that you should know when assessing the child using the ABCD approach. The first one is the actual management should be tailored to the individual patient's needs and the resources available in your specific healthcare setting. The second one is throughout ABCD approach, continuous monitoring, reassessment, and adjustment of intervention based on the patient's response is crucial. The management is based on the patient's specific condition, age, weight, and protocols of the healthcare setting. Always consult and seek expert help in complex cases and when in doubt. Thank you so much for listening and watching. See you in the next video.